All right, can you hear me?
Yes.
Okay.
We can hear you.
Okay. All right, so today I'm going to talk about cervical spondylotic myelopathy. We'll start out with some definitions. So cervical myelopathy is a constellation of signs, symptoms, and imaging findings associated with cervical spinal cord compression. Usually involves difficulty with gait and fine motor coordination, weakness and numbness and non-derbitable distribution. And degenerative cervical myelopathy, if you're reading the literature, is an umbrella term for a cervical myelopathy that is secondary to a degenerative process. There are multiple contributing factors to degenerative cervical myelopathy, including cervical spondylosis, OPLL, or even ossification of the ligamentum flavum. And congenital anomalies can also contribute to it, such as congenital stenosis of the spinal canal. This is just diagrams kind of looking at how cervical spondylosis can contribute to compression of the spinal cord. From both an anterior and posterior perspective, you get increased anterior posterior vertebral body heights, osteophyte formation. You'll have loss of the vertebral body height, which results in ligamentum flavum buckling and hypertrophy. You can get hypertrophy of the PLL and that, or even OPLL, so ossification. And all of these things can contribute to narrowing of the canal and impingement of the spinal cord itself. This is a kind of progressive process, so begins with the discs degenerating and are unable to fulfill their weight-bearing and load-bearing functions, resulting in increased load on the uncovertebral processes. And then this abnormal loading alters the intervertebral joint, which increases stress on the cartilage end plates. In response, the body forms osteophytes in order to try to stabilize this abnormal motion and to increase the weight-bearing surface of the end plates. And then the ligamentum flavum will, also in response, will stiffen, hypertrophy, and will buckle. And that's also as a result of disc height loss and straightening of the cervical lordosis. It can be a dynamic process as well. So this is an example of ligamentum flavum buckling in extension of the neck, and both the buckling of the ligamentum flavum as well as the retrolithesed, in this case C3 vertebral body, can contribute to the stenosis. In flexion, it can be an anterior lithesed body compressing the cord. This is an example of a patient who had both flexion extension MRIs obtained. This patient did not demonstrate any evidence of stenosis during flexion, but you can see during extension, a significant buckling of the ligamentum flavum resulting in cord compression. Ultimately, when you have cord compression, you get...
Hey, Amber?
Mm-hmm.
Sorry, I don't think your screen is up. I'm not seeing it on my
Yeah, I was
end.
gonna say it. Yeah, I'm trying to manipulate everything, but I don't see.
It's not working?
No, you were able to share it earlier, and then I think it disappeared.
Huh. I'm not sure how to... Okay. Is that back up?
Yes.
Okay.
Yep.
Where did it stop sharing?
I think maybe like in the beginning. Yeah, I think that's fine.
Okay. Sorry. So this is an
And
example.
your slide design is on point, so we really need to see these.
I'm sorry. Well, anyway, so this is the degenerative changes slide. This is kind of the aging process spine. These are the dynamic factors kind of contributing to it. And then here is the stenosis MRIs, which are pretty impressive. So again, no stenosis during flexion. And then with extension, you see significant buckling of the ligamentum flavum and cord compression. So ultimately, cord compression leads to kind of a cascade of different events that lead to cord damage. So you'll get mechanical stretch of the spinal cord, which leads to endothelial cell dysfunction and destruction of the blood spinal cord barrier. You'll get alteration of the macro and microvascular architecture, and that leads to compromised perfusion and ischemia, and ultimately apoptosis of the neural element. And then all of these result in a activation of macrophages and microglial activity, and that leads to kind of replacement of the normal neuro tissue with scar, and that ends up with this myelomalacial change that you see on the MRI. So a little bit about history and physical exam. It's a clinical syndrome characterized by difficulty with fine motor movements of the hands. Patients will often describe difficulty buttoning shirts or writing, decreased grip strength, which can present as frequent dropping of items, gait abnormalities and falls. So it's important to inquire about any recent history of falls. Sometimes patients will say they feel uncoordinated or they are bumping into walls when they're walking. They can present with like a myeloradiculopathy, so have radiculopathy symptoms and neck pain in addition to their myelopathic symptoms. And oftentimes, when they present, they describe non-dermatomal numbness or weakness. Sphincter tone changes can occur, but they typically occur later on in the disease process. So with regards to physical exam, motor strength and sensory testing is all important, coordination and balance, Romberg's and tandem gait. And then assessing for the provocative myelopathic signs, including Hoffman's, inverted radial reflex, Babinski, and hyperreflexia. So these are examples of these different findings. So greater than 3 beats of ankle clonus is considered a positive exam. Babinski testing, so upgoing big toe with splaying of the lateral base digits. And then a Hoffman's exam with the flexion of the index and thumb with stimulation of the DIP joint of the middle finger. There is the described myelopathic hand. So this is a constellation of findings, including positive inverted radial reflex, poor ability to grip and release, so doing the multiple grip and release strength test over a 20-second period. The finger escape sign, which is demonstrated on the right, which is basically the patient is unable to hold the index and ring finger together due to interossei wasting and weakness, and then again, diffuse numbness. With regards to the sensitivity and specificity of all of these tests, if you look at this table, it kind of summarizes all of it, but really I think the thing to take home is there's no one test that's super sensitive or specific. They're all fairly more on the specific side than they are on the sensitive side, and we'll kind of talk a little bit more about that in detail. So there's a couple of different papers that reviewed the sensitivity and specificity. This paper found that inverted radial reflex, or also known as the inverted supinator sign, was a 61% sensitive, and the most sensitive of the tests, followed by suprapatellar tendon reflex and Hoffman sign. Clonus and Babinski are not very sensitive findings, but when they're present, they are very specific, so 92 and 96%. And this is a table of their diagnostic accuracy, and as you get more of the Hoffman's, suprapatellar, and Babinski signs, your accuracy and post-test probability increase. This is another paper that looked at the clinical correlation of myelopathy and the Hoffman sign, evaluated 225 surgically treated patients and compiled the data on this. Hoffman's was found to be 68% in 68% of patients, followed by hyperreflexia in 60% and Babinski in 10%. When Hoffman's was bilateral, there was spinal cord compression in 91% of the patients. So it's more sensitive and specific when it is present bilaterally. And then this paper looked at whether or not these cord signal changes actually correlate with findings in cervical myelopathy. And what it found was that the severity of the cord signal change on MRI did not correlate well with the myelopathic signs. So they evaluated 43 patients with cord signal changes. Only 67% had a Hoffman, 60% had a gait abnormality, and 44% had a Romberg sign. So you can have cord signal change without presence of these findings on physical exam. It's also important to consider the paradoxical hyporeflexia that can occur with certain concomitant pathologies, such as cervical foraminal stenosis or severe lumbar stenosis, or in cases where patients may have severe peripheral neuropathy, such as an advanced diabetes. So sometimes people are actually hyporeflexive in those states. And then spasticity is important as well, but this tends to be a later finding. It can also be hard to differentiate patients who may have more upper tract issues above the foramen magnum. Examples they gave in this paper included MS or different types of brain tumors. And one way to differentiate these from cervical myelopathy is to perform the jaw jerk reflex, which is basically a hyperactive reflex that indicates pathology that is cranial to the foramen magnum. So a little bit more about diagnostic imaging. So it's important to get AP and lateral radiographs. AP is useful to evaluate the severity of spondylosis or look at deformity. It's important to evaluate for autoankylosis on lateral radiographs. To the left is the Torg-Pavlov ratio, which when less than 0.8 is has been historically used to identify congenital stenosis of the spinal canal, and we'll talk a little bit more about that in a second. Lateral flexion extension views are important to determine any instability. So this is the paper that looked at the Torg-Pavlov ratio in CSM, and they compared 28 patients with myelopathy to 88 patients without. The study showed that the Torg-Pavlov ratio is significantly smaller with significant statistical findings in myelopathic patients. Their mean average was 0.72 compared with the control patients of a mean 0.95. So this is where that 0.8 cutoff comes from. So what is stenosis when you're looking at the imaging? So you can also use the osseous canal measurement. So an osseous canal measurement of less than 13 is considered to be developmentally stenotic. You can also look at what they consider to be a dynamic stenosis. So if you look at the anterior inferior corner of the, anterior superior edge of the lamina and compare it to the posterior inferior corner of the vertebral body, if this distance is less than 12, it can be suggestive of a potential dynamic stenosis. On MRI, you can also look for things such as cord canal size mismatch. This, not only if your canal is small, but you have a larger cord, that can also make you more predicated to developing myelopathy. And so this can be evaluated with different scoring systems such as the space available for the cord or sac or the spinal cord occupational ratio. This is the paper that discussed the scoring system. You can see them measuring the canal versus the A to P diameter of the cord itself. It's defined as greater than 70% on a mid-sagittal image or greater than 80% on axial imaging, and can be indicative of patients who have a higher propensity for development of myelopathy. On MRI, it's also important to scrutinize the posterior aspect of the vertebral bodies and the PLL. In this case, you see a very thickened, dark, hypertrophied PLL, and this can signify a patient who may have OPLL. And the idea here is to have a high index of suspicion to get a preoperative CT in order to appropriately plan for surgical intervention, and we'll talk more about that in a bit. So don't forget about OPLL. Here are the radiographs that demonstrate the different types of OPLL. You can have localized, segmental in B, continuous and mixed, and continuous in C and mixed in D. A little bit about the classification system. So Nurix began the classification system. That is his original paper that discussed cervical spondylotic myelopathy and classified it on the basis of symptoms and lower extremity functional status. The criticisms of this classification was that it did not include an assessment of the upper extremities, and it was difficult to use in the elderly, which resulted in the development of the Ranawat classification, which improves upon the Nurix scale by including both a subjective complaint as well as objective findings. But there's only 3 classification groups and was more difficult to appropriately stratify patients, which led to the development of the MJOA score, which we use now. This includes both upper and lower extremities and includes bladder function. It also stratifies patients based on the severity of their myelopathy. So mild myelopathy is considered to be from 15 to 17, moderate from 12 to 14, and severe as 0 to 11. Here are the minimal clinical important differences for MJOA when you're looking at the literature. One, a change in score of 1 for patients with mild myelopathy is considered significant versus 3 for severe myelopathy. As far as the natural history goes, it is one of stepwise deterioration. These are the 2 original papers that described the natural history, both by Nurek as well as Lees and Turner. The disease is largely characterized by periods of stable disability, punctuated by these intermittent exacerbations of significant decline. And both Nurek and Lee and Turner kind of found that and described that. So I think the hard part comes when you're trying to decide who to operate on and who to watch. And so the AO Spine and Global Spine Journal published these recent guidelines to help with determining when patients should undergo surgical intervention. They did 5 systematic reviews of the literature and evaluated the natural history, the risk factors of disease progression, efficacy and effectiveness of surgery, and then the impact of the duration of symptoms and severity. So for moderate and severe degenerative cervical myelopathy, they recommended pursuing surgical intervention. For patients with mild degenerative cervical myelopathy, they suggested offering a trial of non-operative structured rehab with close clinical follow-up, anywhere from 4 to 6 months. And then if there's obviously any deterioration, they recommend pursuing operative intervention. In the so then the question was, well, what if the patient has spinal cord compression but is not myelopathic? And so with regards to non-myelopathic patients with cord compression and no radiculopathy symptoms, they do not recommend offering prophylactic surgery. They suggest in these patients that they be counseled on the risk of progression and the signs and symptoms to watch out for, and then just be followed clinically. This is in contrast to patients who do have radiculopathy symptoms and signs of cord compression on MRI. These patients are at a higher risk of developing myelopathy based on literature review. And so they said, you can do either thing. You can follow them clinically and offer non-operative treatment, but it needs to be closer clinical follow-up versus just offering surgical intervention in those patients. So when we talk about surgical intervention, there's a whole host of options, and it becomes kind of a bit of a bear. So I tried to break it down into different portions of the literature. So is surgery safe, and does it provide benefit or just prevent decline? Because we always talk about the main point of this surgery is to prevent you from declining further, but do we actually provide benefit for patients? So this was a recent study published by AO. It was a multi-center prospective study that involved 12 North American centers from 2005 to 2007. They categorized myelopathy into mild, moderate, and severe, and then they followed these patients prospectively after surgery and looked at MJOAs, Nurex, NDIs, and SF36s. And then once they had their results, they did a multivariate analysis and stratified the patients based on their MJOA classification. So 278 patients, 85 had mild cervical myelopathy, 110 had moderate disease, and 83 had severe disease. There was a significant improvement from baseline to 1 year postoperatively in all scoring systems, and that did meet the minimum clinical important difference. The degree of improvement did not depend on the severity of the preoperative symptoms. So even if you had mild myelopathy or versus severe, it didn't show a significant difference between those patients. And that's kind of what it's talking about when it says that these remain unchanged after using the confounders in the multivariate analysis. So these are the tables that were kind of presented showing the improvements in the MJOA, Nurek, NDI, and SF36. This was just in general, and this is the table that stratifies them based on mild, moderate, and severe myelopathy. So there are other factors to consider. What about complication rates? So this study looked at the perioperative complications that can occur. It was a study of 302 patients, and they looked at all approaches, anterior and posterior. Posterior approaches were associated with higher infection rates. Anterior approaches were associated with higher rates of dysphagia, and both approaches had equal rates of C5 nerve palsy, which varies in the literature. I have a study coming up that showed higher C5 nerve palsy rates in posterior approaches, but then an additional study that showed equal. Universally, though, increased complication rates were associated with increased OR time and EBL, and so it's important to be cognizant of that when you're in the OR, that these do show increased complication rates the longer you're in there. As far as stratifying based on posterior approach, the only difference they found between laminoplasty and posterior fusion and decompression was exactly what we had just spoken about, which is the operative duration and surgical EBL. They were significantly higher in posterior decompression and fusion patients. So how do I decide versus an anterior versus posterior approach? Well, based on the literature review, ACDF is considered the gold standard treatment for single level to two level disease, particularly in the setting of anterior pathology or in the setting of cervical kyphosis. But there are some situations where ACDF is really contraindicated. That would include stenosis from a primarily posterior pathology, or if the pathology remains more located behind the vertebral body rather than the disc space. OPLL is important to consider, and then in patients with significant multi-level stenosis greater than 3 levels of disease. So why no ACDFs for greater than 3 level pathology? Based on the literature, it's based two main reasons. So an inability to achieve complete decompression behind the mid-vertebral body, and then higher rates of pseudoarthrosis due to increased number of graft host interfaces. So then the answer to that was, well, why don't you just do anterior cervical corpectomy, which can be done. It has multiple advantages, including limiting those number of graft host interfaces, and can facilitate more extensive decompression to the posterior vertebral body and provide a significant amount of local autograft. However, there are a higher incidence of complications, and I'll show a paper showing that here in a second. Including possible graft extrusion due to fewer points for vertebral body fixation with the plate fixation. And these have been found to have worse correction of cervical lordosis when you compare them to multi-level ACDF procedures. So this was a retrospective analysis that looked at cervical corpectomies. They reviewed patients who underwent 33 2 levels and 7 that underwent 3 level anterior cervical corpectomies. Importantly, they used a fixed plate design, which is a cervical spine locking plate, and they evaluated their NURIC and MJOA scores and followed them for about 32 months after surgery. What they found was that only 2 of the 33 patients that underwent a 2 level fusion developed reconstruction failures, but that was in contrast to the 5 of the 7 who underwent a 3 level corpectomy. And so they basically said that if you need greater than a 2 level corpectomy, you should really consider adding posterior fixation because they have high failure rates. And this is an example from their paper demonstrating graft failure and a plate pullout. So they recommended adding posterior fixation, citing improved fusion rates and decreased failure. And the critique of the paper was that, they were using locking plates, but then if you look at the literature further on, even with the non-locking plates, they do have significant higher failure rates. So why do these plates fail in multi-level anterior reconstructions? It has to do with the instantaneous axis of rotation. It's normally located in the posterior vertebral body. But if you have an insult to either the anterior or posterior elements, the IAR will move away from the instability. In this case, a patient had a posterior ligamentous complex injury, and so the IAR moves to the anterior vertebral body. In the setting of a corpectomy, the IAR actually remains in the posterior vertebral body if you don't add a plate. And so flexion will load the graft and extension will offload the graft. But when you add a plate to the fixation for the surgery, the IAR actually will move anteriorly, and flexion now loads the plate rather than the graft. And so the extension maneuver will then load the graft rather than the flexion maneuver and can kick the graft out or cause subsidence into the lower vertebral body. So this is an example of that graft kick out and plate failure. So if you add posterior fixation, it actually moves the IAR back to the posterior vertebral body. The flexion will again load the graft, which improves fusion rates. Extension does not load the graft, and overall you get better fusion and less failure. So what about the posterior-based approaches? There's laminectomy alone, laminectomy and posterior fusion, and laminoplasty. Historically, laminectomy without fusion was kind of universally used, but this resulted in several disadvantages, including the development of post-laminectomy kyphosis. So unless you're doing kind of skip levels of laminectomy, we don't typically do this anymore. We pursue either laminoplasty or posterior fusion. So in laminoplasty, patients who have ideal indications are those with multi-level myelopathy, preserved lordotic alignment, and no axial neck pain. The advantages are a form of indirect decompression and expansion of the cord, the canal. It's a motion preserving procedure, and it allows kind of skip segments or at-risk future segments to be addressed in one operation without increasing the morbidity of the procedure. So how does that fare versus a multi-level corpectomy? This paper compared 42 patients who underwent laminoplasty versus 41 patients who underwent a multi-level cervical anterior corpectomy. Neuro improvement was similar between the two groups, but the complication rates were significantly lower, 7 versus 29% in the laminoplasty group. There are contraindications to laminoplasty, so preoperative kyphosis is one. These posterior-based procedures rely on cord drift back, which can occur in patients with lordotic spines and neutral alignment, but do not occur with kyphotic alignment. 1 or 2 level disease that can be treated anteriorly would be a contraindication, and then preoperative generalized axial neck pain, as neck pain can worsen or will definitely still be present after the surgical procedure. This is an example of the sagittal alignment and cord drift back. On the left, A and B demonstrate a lordotic spine with the cord floating back after a posterior decompression. On C and D, you can see the kyphotic alignment and the cord remains draped across that anterior pathology. So this is a paper that showed the reduction of the surgical outcomes of laminoplasty based on the presence of local kyphosis. It evaluated 114 patients and then looked at their MJOA scores to evaluate their surgical outcomes 2 years after surgery. There was improvement before and after surgery, and the overall recovery rate was 60.2%. But most importantly, they showed that if the patient demonstrated high intensity signal change on MRI, or if there was significant local kyphosis, those were risk factors for poor surgical outcome. And they cited that the local kyphosis exceeding 13 degrees was really the cutoff point. What about the surgical strategy for multi-level stenosis and OPLL? This is a paper that then compared posterior fusion against laminoplasty and anterior procedures. 75 patients were evaluated. With regards to alignment parameters, lordosis was more improved than with posterior decompression and fusion and corpectomy. So the caveat here is that some patients can develop a laminoplasty postoperative kyphosis, which did not occur in the corpectomy and posterior decompression groups. The JOA neuro scores in this surgery or this study were better with laminectomy and fusion and anterior corpectomies. Anterior approaches had higher CSF leaks. Posterior approaches had higher C5 nerve palsy rates, although that depends on what paper you're citing. And then axial neck pain was greater in the laminoplasty group. So what about just laminoplasty versus actual posterior fusion? This procedure, or this meta-analysis evaluated 7 studies comprising 302 and 290 patients treated with laminoplasty versus fusion. Both treatment groups showed slight cervical lordosis and moderate neck pain at baseline states, and then they were evaluated based on their MJOA. Both improved with regards to their MJOA, and in this group, both groups evenly lost cervical lordosis, interestingly. So it doesn't always, laminoplasty doesn't always show that post-operative kyphosis. It kind of depended on which paper I was reading. This paper cites potential reasons why patients might have a postoperative kyphosis, and could be a whole grand rounds in itself, but a preoperative higher T1 slope can be associated with it. So just stratifying your patients and choosing appropriately there. And then what about progression of OPLL? So one of the caveats to laminoplasty is that OPLL actually progresses in that setting versus the fusion setting. So OPLL will continue to progress in the setting of motion sparing, and that's the whole idea with laminoplasty. Whereas with fusion, you can actually see regression of the OPLL and decreased progression. So in this paper, it showed OPLL progressing at 62.5% for the laminoplasty group and only 7.6% for the fusion group. So do outcomes change based on the anterior versus posterior approaches? The two main systematic reviews that I looked at basically showed that both approaches can be effective. Posterior approaches increase canal diameter changes more. In these studies, the postoperative C5 nerve palsy rates were similar. Infection rates are lower with anterior surgery, which seemed to be similar across the board. Dysphagia rates were lower with posterior surgery. So in general, in the literature, there's a trend towards anterior surgery for limited pathology and a trend towards posterior surgery for multi-level pathology. And this was actually a randomized controlled trial that compared the two types of surgery. And ultimately, they found that the outcomes were very similar. The complications differed. And that in this paper, laminoplasty was associated with less health resource utilization. So have an algorithmic approach to whatever you're doing. This was a really nice review that reviewed the literature and then offered a strategical approach based on alignment of the cervical spine, number of levels that needed to be treated, and considerations with OPLL or other forms of ankylosis. And there are multiple different algorithms out there. I thought this one was kind of nice and had most of the factors taken into consideration. Okay. I tried not to go over too much. It's a big topic.
It is, but you're doing a really good job. The one thing, Amber, that I think it's still hard for me, and it seems like the needle moves a little bit every couple of years, is those folks in like the mild myelopathy category. Mm-hmm. And even when we were at that meeting in Colorado recently, it seems like folks are a little bit more aggressive. You know, a lot of that comes from Mike Fellings in Canada. He sort of, I think, is the leader on that front. But I don't know. That's a hard one for me with the folks that have the MJOA scores that are like, 13, 14, 15. Can you watch them? I think it's a little bit gray still. And the other question I have for folks is, what if you have somebody that's really not too myelopathic, but they've got core compression and some T2 signal? Does that push folks over the edge to try to recommend surgery, even if they're relatively asymptomatic?
No, generally not. I mean, I think that's been dealt with in the literature to a large degree.
Yeah.
That the imaging's not by itself a good arbiter of who to operate on.
Yeah.
But I don't know that we've put it to rest. I think the newer imaging the stuff that Phalanx has been working on, I think that may, if we can get that more commonly accomplished widespread, maybe we find that to be a better proxy for when to operate.
Maybe some like predictive analytics associated with it if they follow them longitudinally. That would be interesting.
Yeah, right. Still a little hard, I think, if somebody's asymptomatic and not manifesting neurologic duress on exam, to think that you're going to do them great favor. And it's worth the risk of actually causing trouble, because despite our best intentions, we do introduce some risk of neurologic injury even when we have good technique and everything seemingly goes well. People take a nosedive, and then you're like, oh great, you were asymptomatic. Now you can't lift your arm, or you've had a cord reperfusion injury, and they hate you.
And many of them are elderly, so
Right.
that certainly contributes.
I suppose the other thing is, like, are you dealing with, focal myelopathy versus sort of the widespread version, right? Because if it's a 1-level ACDF, then, the risk may be okay there. I'm thinking about me personally, like if it was just like an ACDF versus needing, a 4-level laminoplasty or, a lammy fusion.
You mean an ACDF and I can't swallow afterwards?
Yeah, that one.
Yeah.
But I'd still probably be willing to, you know what I mean?
Yeah.
Like I still
Yeah.
think the risk
No,
pool
but
is.
Greg, you make a good point. Like if I
Yeah.
had 5-6 disc degeneration and I had cord compression there, but I wasn't having myelopathy, I'd probably have an ACDF or maybe an
Yeah, me too.
arthroplasty.
Yeah.
Just because the consequences of
Yeah.
a big develop and the relative. Bob's point is well taken, but I mean, most of our ACDF patients are going home the next morning without, especially the 1 levels, without a whole lot of recovery or morbidity.
Right.
Versus the asymptomatic that needs a 4-level, right? Like
Right,
those are the
right,
ones that are like, oh freak. Let's
Right.
watch it. Great job, Amber.
Great job,
Good stuff.
Amber.
Yeah, big topic.